Hello, this is Mrs. Ignacio, and we are talking about genitourinary system disorders today. Let's jump in, and before we do that, let's talk about the NCLEX test plan. So this is the NCLEX test plan breakdown for the RNs. As you can see, this pie chart that kind of tells you the areas that the NCLEX will test you on. So this is going to be important as you do your questions in Saunders and Kaplan and Hurst to make sure that you're focusing on the appropriate areas. And for example, if you have management of care, that's 20% of the NCLEX for the RNs. If you're not doing very well in that section, you really want to focus because that's a large chunk of your NCLEX. So you might want to focus on that area. This is the distribution of content for the NCLEX PN. And for the NCLEX PN, a huge chunk is going to be coordinated care. That's 21%. So this can be found for both RN and PN at the NCSBN website. Okay. So when we are studying particular systems, we want to go back to the anatomy and the physiology. That's going to be very important. And if you have any questions throughout this session, please make sure that you're putting them in the chat, or you could raise your virtual hand and I will pause to answer your questions because there's going to be a lot of information. Okay, so when we talk about the assessment of the kidney and the urinary system, it's important to understand what the functions of the kidney are. So the kidney regulates acid-base balance. The kidney also regulates fluid and electrolyte balance. Okay, so the kidneys also serve to excrete metabolic waste such as creatinine and urea. The kidneys regulate blood pressure via the renin-angiotensin system. And so the renin serves to stimulate, or it's stimulated by decreased blood pressure or blood volume. And so this then stimulates the production of angiotensin 1, which is converted to angiotensin 2 in the lungs. Angiotensin 2 is a strong vasoconstrictor and stimulates aldosterone secretion. Vasoconstriction and sodium reabsorption results in increased blood volume and increased blood pressure. Another function of the kidneys that it secretes erythropoietin, and erythropoietin is essential, an essential hormone in the making of red blood cells. So the erythropoietin is made by the kidneys and then sent to the bone marrow where the red blood cells are made. The kidneys also help to convert vitamin D in its active form for absorption of calcium. And the kidneys also help to excrete water-soluble medications and medication metabolites. So an important thing to note is that minimum urine output that we're looking for in our patients is 30 mLs per hour. So we start to get concerned if a patient doesn't have that minimum output. So contributing factors to genitourinary disorders could be that they actually have a history of genitourinary disorders. They may have a history of hypertension, a history of diabetes. They may have a family history of renal disease, such as PKD, which is polycystic kidney disease. They also may suffer from incontinence, BPH, which is benign prostatic hypertrophy. They may have a history of cancer or kidney stones. The patient may also be taking nephrotoxic medications. So these are all things that we need to think about as we are examining our patient that has any genitourinary system disorder. So you may be wondering, well, what are the manifestations that I could expect to see with these kinds of disorders? Well, flank pain that could radiate to the upper thighs, the testes, or the labium, in females, testes in males, and the labium in females. Also, the manifestations in your genitourinary disorder patient may be changes in voiding. So they may have hematuria, which is blood in their urine. They may have proteinuria, which is protein in their urine. Dysuria, which is difficulty or painful urination. They may experience frequency, which is I go many times in an hour, or urgency is like I have to go right now. They also may experience burning upon urination, nocturia, which is nighttime urination, incontinence, which is the inability to hold a bladder's contents, polyuria, which is excessive urination, oliguria, which is going to be less than 30 mLs of urine per hour, or anuria, and A is without, and they're without urine. So let's just pause for a second and talk about anuria. If your patient does not have urine, that's going to be a cause for concern. The only patient that really may not have a urine output is going to be your kidney patient or your dialysis patient. Okay, and we'll talk a little bit more about dialysis a little bit later. Other manifestations that you may see in your patients with a genitourinary system disorder is thirst, fatigue, or generalized edema. I'm going to pause for a second to see if there's any questions. Okay, there appears to be no questions, so I will continue on. Okay, so we'll take a look at the tests that go with the genitourinary system. So as you study a particular system, right, you go back to the anatomy and physiology of it, and then you think about what are the diagnostic tests to test this particular body system. So in this case, we're going to talk about those tests for the genitourinary system. Urinalysis can be given, and we can have specific gravity of the urine. We're also looking at the color of the urine, and urine should be a yellow, amber, or clear color. We're also testing when we do urinalysis for glucose. We want the urine to be negative in glucose and negative in protein, nitrites, red blood cells, and white blood cells. We're also looking at the pH. The pH should be acidic. Also, when we think about collecting a urinalysis sample, the best time to collect a sample is going to be the first void of the morning, as soon as that patient wakes up. When we collect these urine samples, we will immediately send them to the laboratory, or if it is a 24-hour urinalysis, we will keep it refrigerated or on ice. So if we're doing a 24-hour urinalysis, the first void of the day will be discarded, and all subsequent voids will be retained and kept in a container that is going to be refrigerated or on ice. If we are conducting a clean catch sample for the patient, that is done if we have to collect a urine culture. We have to give 3 antiseptic wipes. Instruct the female patient to wipe on each labia with each antiseptic wipe. And then the third wipe will be to wipe in the middle to cleanse the urinary meatus. For your males, you will instruct them to use their 3 wipes, starting at the head or the tip of the penis and working their way down the shaft. Okay, so that's going to be important. After they clean, they will start to urinate and they will stop midstream. Then in a sterile container, they will collect their urine sample. Okay, that's going to be really important for that clean catch. Okay. So let's now talk about renal function tests. So there's probably going to be several tests over a period of time for your patient with this renal condition. So we're looking at the BUN, which is the blood urea nitrogen, and an increased BUN may indicate a number of things. And this is going to be important because I've seen a lot of these kinds of things on test questions. So an increase in BUN may indicate hepatic or renal disease. And remember, hepatic is your liver. So an increased BUN may suggest that the patient has a liver disease or a kidney disease. The increased BUN may also indicate dehydration or decreased kidney perfusion. So that means not enough blood is getting to the kidneys. The increased BUN may also indicate a high protein diet. It may also indicate infection, stress, steroid use, or GI bleeding. Recently, I have seen a question on GI bleeding with an increased BUN. Okay, so again, the increased BUN may indicate hepatic or renal disease, dehydration, or decreased kidney perfusion, a high protein diet, infection, stress, steroid use, or GI bleeding. Okay, so that's one of the tests that we'll use, the BUN. The second test that I want to mention is the creatinine. The creatinine test is the best measure of renal function. Okay, so that is, sometimes you may hear the gold standard. That is going to be the best way to determine someone's kidneys function or their renal function. And when you hear renal, you think kidney, think urinary system. So this creatinine test, we can have the 24-hour creatinine clearance test, and we're going to have the patient void, and we are going to have them discard or throw away that first specimen. And then when we do that, we will collect all urine for the next 24 hours. This urine must be free from toilet paper. It must be free from feces as well. So that if we miss, right, collecting one sample, we have to start all over again. Okay, so we will stop at the completion of 24 hours, and the test is stopped following the patient's last void over a 24-hour period. But remember, that first void of the morning is going to be discarded. So there's also another test that we could do to test our renal function is going to be uric acid. We're going to determine the amount of uric acid that is in the urine. And when I say uric acid, you may be thinking, that makes me think of gout. And that is correct. Gout is a condition, a musculoskeletal condition where the patient has uric acid crystals that actually build up in their joints because they have a diet high in purines. So we want to make sure that we do some patient teaching with that kind of patient. Now, going back to our renal function test, the next test that's possible is going to be the prostate-specific antigen test. And that's only for males because males are the only ones that have prostates. So the prostate-specific antigen test, we want to understand that greater than 10 indicates a risk of prostate cancer. So again, the prostate-specific antigen test is only for males as they only have prostates. If it's greater than 10, it indicates a risk of prostate cancer. Something to remind our patients about is the prostate exam for males that are 50 and older. A lot of times, males will not get this exam because it is actually a digital exam where the provider has to go in through the anus and do some palpation to check on the prostate. Let's now go to radiological tests. So when we say radiological tests, it's nothing more than an X-ray. Okay, so you may have the doctor order what's called a KUB, and that stands for kidneys, ureters, bladder. And so this x-ray shows the size, shape, and the position of the kidneys, the ureters, and the bladder. There is no preparation necessary for this test. However, we do have to confirm that our female patient is not pregnant. That is very important. There can be an IV pylography that's done, and this is going to be performed with contrast dye. So whenever we use dye, we also always have to assess for allergies, right? To shellfish, to iodine, okay? Whenever you see IV contrast, always know that that's something that we do. We have to assess for allergies because we don't want this patient to be allergic to this dye, okay? And then we administer the dye. So with this IV pylography, the contrast dye, it is going to help to visualize the structures of the urinary system, the kidneys, the ureters, the bladder, and the urethra. When a patient has these radiological tests, some of the things that we have to think about as our nursing interventions is to verify that the informed consent has been signed, verify the patient's last creatinine level. The client should remain NPO for 8 hours. Fluids may be permitted, but that's going to be based on the doctor's order. We will administer laxatives as prescribed. They may administer laxatives to clear the abdominal cavity so they'll be able to clearly see the urinary system, because we don't want intestines that are full of waste, because that can actually block what the doctor is trying to see. We may have to administer an enema or a suppository on the morning of the test only as necessary. So we also must assess for allergies to iodine or shellfish. We also want to inform the client of potential sensations during the exam. So this is going to be really important, because if you've ever had a CT done and with dye, it does have a burning sensation. So you want to let the patient know that they're going to feel some flushing or some warmth. They may feel a little nauseous, right? Or they may have a metallic or salty taste in their mouth as that dye is put through the IV. You also want to make sure that emergency equipment is readily available during the test, right? So that code cart should be there. Any medications that are going to be ordered by the doctor in case the patient has an allergic reaction to the dye. We also want to encourage fluids post-procedure to make sure that the patient flushes the dye out of their system, okay? So let's now talk about renal angiography. So this is going to be a visualization of renal arterial supply. So we're looking at these renal arteries. So contrast material will be injected through a catheter. So the nursing interventions for this renal angiography is going to be understanding where the approach is going to be made. Usually the approach, meaning where they're actually going to insert the catheter so they can inject the dye, is usually made through the femoral, which is in the groin, or the brachial artery. So we have to understand where that approach is going to be made. Where is the doctor actually going to insert the catheter? Okay, and so we have to cleanse that area with the appropriate cleanser as dictated by your institution's policy, right? And one thing that's really important, right, before this procedure is to locate and mark the peripheral pulses, the pulses that are most distal. So if there's going to be a femoral approach, we want to especially assess the most distal, which is pulses, which are going to be the dorsalis pedis pulse, which is the pulse on the top of the foot, right, by the greater toe, between the first toe and the second toe. Okay. We also want to have the client void before this renal angiography. And we are also going to explain to the patient that the procedure may create a feeling of warmth along the vessel. Okay, so it's good to give them a warning about that ahead of time. Now, post-procedure, this patient is going to maintain bed rest for 6 to 8 hours post-renal angiography. We will monitor the patient's vital signs until they are stable, keeping in mind that the LPN is not allowed to care for. We cannot delegate care of an unstable patient to that LPN. The other intervention to think about is observing the client for swelling, right, or edema, or a hematoma. A hematoma is a blood bruise. Now, they may have a small blood bruise at the insertion site, but if that begins to become large, we will have to notify the provider because that is an unexpected finding. We will also post-procedure palpate the peripheral pulses and perform vascular checks, right? We're checking to make sure blood is able to flow and it is bilateral, it is symmetrical, it's on both sides. We will also monitor the patient's eyes and nose, including the urinary status. And eyes and nose means intake and output. Whatever's going in, if they're drinking, if they're getting anything by IV, and whatever is coming out in the form of urine, it could be emesis or vomitus, we have to document that. It all is included in our intake and output or eyes and nose. Okay, let's talk about cystoscopy. Whenever you see oscopy, think of a camera, a flexible camera being inserted inside of the patient to take a look at whatever the system that we're talking about. In this case, the cystoscopy is an invasive procedure in which a scope is passed to view the interior of the bladder, urethra, or the position of the urethral orifices, right? And so those openings, because we're looking to see if there's any urinary calculi or kidney stones or urinary stones, right? Calculi are going to be stones. And they may also look to see if there's any stones in the urethra, the bladder, or the ureters. And this cystoscopy is also used to possibly treat lesions of the bladder, urethra, and the prostate. So you may be thinking, well, what does the nurse have to do before the procedure? Well, great thinking. We have to make sure the patient maintains an NPO status if the patient is to be given general anesthesia. We will administer the preoperative cathartics, enemas, right? Any cleansing medications that need to be administered, we will administer them per the doctor's order. We will also teach the client deep breathing exercises to relieve any bladder spasms. We also want to monitor for postural hypotension. And what is postural hypotension? Well, when the patient changes position from lying to sitting to standing, their blood pressure may drop, right? So we want to monitor for that. We also want to do some teaching with the patient and letting them know that pink tinged or tea-colored urine is common following the procedure, but bright red urine or clots should be reported. So this is a huge concept to understand for test questions, right? So anytime a patient has bright red blood and there's clots in pretty much any body system, we want to notify the provider immediately. So the last nursing intervention I'm going to mention for pre-procedure for the cystoscopy is going to be providing non-pharmacological pain management techniques. Teach them about this before the procedure, right? Because after the procedure, they may be groggy, they may be a little confused, they may not really remember. So you want to do all of this teaching while they're in their right state of mind before they get any medications. Now, post-procedure, right, we want to assess for leg cramps because this patient is going to be in the lithotomy position for a long time. And so the lithotomy position is also the position that is used for a well woman OBGYN exams where the legs are elevated and spread apart. So we want to make sure that we're assessing for leg cramps, we're assessing for back pain or abdominal pain, and we can also offer the patient a warm sitz bath for comfort. We will also push fluids and provide analgesics as required. And we will carefully monitor the patient's I's and O's. Okay, all right. The next procedure we're going to talk about for or diagnostic test is going to be a renal biopsy. Whenever we think of biopsy, I want you to think of the system that we're examining and how will we position the patient, informed consent, right? Those are all things to think about for any biopsy. With a biopsy, in general terms, the provider is going to go in with a needle to remove fluid, cells, and tissues. Those cells and tissues will be sent to the pathology lab to determine are there any abnormal cells? If so, what are they? So nursing interventions before the patient goes in for a renal biopsy is we're going to obtain bleeding, clotting, and prothrombin times. Well, that makes sense because we don't want to perform a biopsy on a patient that has been taking these anticoagulants and that has an increased risk for bleeding. We will also obtain results, pre-biopsy results of the x-rays of the kidney. We will administer IV fluids. That means that the patient has to have a working and patent IV. We will also maintain an NPO status for 6 to 8 hours. An NPO means nothing by mouth. Position the client with a pillow under the abdomen and shoulders on the bed, and verify that the informed consent is signed and inside of the patient's record. And that's, again, I just want to emphasize that's for any procedure, because if not, we can face liability, right? So we want to make sure that that informed consent is signed and in the patient's record. We want to instruct the client to remain very still during the procedure. Now, post-renal biopsy, we want to maintain the client in the supine position. Supine meaning they're lying on their back, right? And so they should remain in bed for 24 hours. We will monitor the client's vital signs every 5 to 15 minutes for 4 hours. The reason why we're doing this, because we're looking out for signs of hemorrhage, okay? Whenever my patient has an invasive procedure, I always worry about hemorrhage and infection, and hemorrhage will kill the patient faster. So I want to look out for that. That's why we're going to monitor those vital signs, because if the blood pressure is dropping, that could be a sign that the patient is hemorrhaging or bleeding. We will also maintain pressure to the puncture site for 20 minutes. We will observe the client for any pain, nausea, vomiting, and blood pressure changes. We will also encourage fluid intake. We will assess the patient for their hematocrit and hemoglobin 8 hours after the procedure. We will also monitor the client's urine output, and we will make sure that the client avoids strenuous activity, which is sports, heavy lifting, and that's going to be at least for 2 weeks. All right, so that is all about the renal biopsy. I'm going to pause for a moment to see if there's any questions. Okay, there doesn't appear to be any questions, so I'll discuss the indwelling urinary catheterization. So this is a sterile procedure to empty the contents of the bladder. We can obtain a sterile urine specimen determine the residual urine, and initiate irrigation of the bladder or bypass an obstruction if the patient has, for example, a kidney stone or urinary calculi. So the nursing intervention for the indwelling urinary catheterization will be to maintain a closed system, monitor and measure the client's urinary output every shift, provide meticulous perineal care, and that includes not only cleaning the peri area, but also cleaning the tubing of the urinary catheter. We will keep the drainage bag below the level of the client's bladder. We will increase daily fluid intake. We will prevent dependent loops in the catheter tubing. So what does that mean? We have to trace the tubing, make sure that there's no kinks, and make sure that that bag stays below the level of the waist of that patient. And if we're placing it on the bed, we'll place it on a part, that urinary bag, right? We will place it on a part of the bed that does not move. The other thing that's important when we talk about indwelling urinary catheterization is that we want to discontinue the use as soon as possible because the patient has an increased risk for urinary tract infection. Okay, let's now go to our conditions. I'm going to pause for a second to see if there's any questions. Okay. I don't see any questions, so we'll talk about cystitis. Cystitis is an inflammation of the urinary bladder. If a patient wipes from back to front, they can contaminate themselves with E. coli. So we want to teach our patients to wipe from front to back, especially our female patients. Prolonged baths with excessive soap can be common in females that can contribute to cystitis. In males, BPH may be a contributing factor. Also, patients that have indwelling urinary catheters may also be at risk for cystitis. What are the manifestations of cystitis? Frequency and urgency, and only voiding small amounts of urine each time. Dysuria with hematuria. Suprapubic tenderness, pain in the bladder region or flank pain, fever, malaise, chills, cloudy, foul-smelling urine. So the urinalysis may also reveal increased protein and white blood cells, presence of leukoesterase, casts, and bacteria. So how will we care for this patient with cystitis? Well, we will obtain the patient's clean catch urine sample and send it away for culture and sensitivity before initiating antibiotic therapy. We will maintain acidic urine pH for that patient. They will push fluids greater than 3,000 mLs per day. Also encourage the client to drink cranberry juice. We can also apply heat to the perineum for comfort. The medications that we may see administered for cystitis include antimicrobial medications such as sulfonamides. Be sure to assess for allergies for sulfa. We may also administer urinary analgesics. The medication of choice could be phenazoperidine. And then we have to make sure we inform the patient that with this medication that it may turn their urine orange. So I have seen some questions where we have to advise the patient that it may stain their underwear. They may need to wear a protective pad. And the third class of medications that can be given can be antispasmodics, which is your hyoscyamine. Okay, so client education and referral. Remind the patient that peri-care is going to be important, wiping from front to back, wearing cotton underwear is going to be important, avoiding bubble baths, maintain increased fluid intake, avoid before and after sexual intercourse, and to drink cranberry juice daily. All right, we will continue, but let me pause for a second to see if there's any questions on cystitis. All right, we'll continue on to acute glomerulonephritis. This is an acute renal disease involving renal glomeruli of both kidneys. Okay, this is thought to be an antigen-antibody reaction that damages the glomeruli of the kidney. This may be secondary response to infection in any other part of the body, and it usually occurs in children. The prognosis is good if treatment is implemented. So what are the contributing factors to acute glomerulonephritis? Well, a beta hemolytic streptococcal infection, and it can also follow tonsillitis or pharyngitis. So the manifestations of acute glomerulonephritis, hematuria, or cola or tea-colored urine with proteinuria, and that is protein in the urine. There may be edema, especially facial edema and periorbital edema. That's edema around the eyes. The patient may also have ascites. Ascites patients have round, protuberant abdomens because their abdominal cavity is filled with fluid. The patient may also manifest with oliguria or anuria. Remember, oliguria is less than 30 mLs of urine per hour. Anuria is A is without, so without urine. They may also manifest with hypertension and a headache, azotemia, which they'll have toxicity due to high nitrate levels. They may have flank or abdominal pain. They may also have anemia. So what is the collaborative care for this patient with acute glomerulonephritis? Well, for the nurses, we want to have this patient maintain bed rest to protect the kidneys, restrict fluids, increase calories and reduce protein and sodium in the diet, and monitor the daily weight. Remember that if a patient gains more than 2.2 pounds in a 24-hour period, that is a cause for concern because 2.2 pounds is equal to 1 liter. And if a patient is retaining 1 liter of fluid, that is a cause for concern, and we have to notify our chain of command. The medications for this patient with acute glomerulonephritis will include penicillin for the streptococcal infection. However, again, remember to assess for allergies to penicillin. Okay. We also may administer corticosteroids for the inflammatory disease. Also, antihypertensives can be administered for increased blood pressure. All right, any questions on acute glomerulonephritis? All right, well, we're going to continue on with nephrosis. Now, nephrosis is a clinical disorder that is associated with protein wasting, secondary to diffuse glomerular damage. So there's damage to the tiny clusters of blood vessels that are in the kidneys. So the contributing factors to nephrosis is that it may be an autoimmune condition, right? And the glomerular membrane is more permeable, especially to protein. So we have to understand that about the anatomy and the physiology of the kidney, of the nephrons, and when we go zoom into the nephrons, that glomerular capsule. The manifestations of nephrosis is that it can have an insidious onset. So the patient may have pitting edema. And when we think about pitting edema, it's best checked on the lower extremities over the shins. We will depress with our index finger and we will see if the skin bounces back or if it stays pitted for a period of time. The longer that that skin stays depressed is going to indicate the severity of the edema. So it could be +1, +2, +3, +4, 4 being pretty severe. We also have to look out for generalized edema, which is known as anasarca. Anasarca. The other manifestations of nephrosis could be proteinuria, anemia, hypoalbuminemia, hypo being low. Albumin is the protein that helps blood to stay in the blood vessels, right? So if the patient is low, that means that fluid is going to be leaking out of the blood vessels and getting into the interstitial spaces or in the tissues. Thus, the patient will have edema or swelling. Other manifestations of nephrosis can be anorexia, malaise, or nausea. Also, oliguria, ascites can be manifestations of nephrosis. So our nursing intervention for this patient with nephrosis is maintaining bed rest during periods of severe edema only, because we want to preserve the renal function. We also want to maintain a low sodium, low potassium, moderate protein, high calorie diet. So we'll maintain a low sodium, low potassium, moderate protein, high calorie diet. We will protect the client from infection, monitor their I's and O's, weigh the client, and measure abdominal girth daily. Medication therapy for this patient may consist of loop diuretics. For example, your furosemide, which is Lasix. On the NCLEX, you will see furosemide, not Lasix. Steroids include prednisone, and then your immunosuppressive agents may be cyclophosphamide. Okay, so that is it for nephrosis. Any questions about nephrosis? Okay, we're going to now go to urolithiasis or urinary calculi. So these are stones. Whenever you see lithiasis, they're stones. And we have stones in the urinary system that can be in the kidneys, the ureter, the bladder, or the urethra. So contributing factors to urolithiasis or urinary calculi can be obstruction or urinary stasis. The patient is not emptying their bladder. Uric acid stones, excessive purine intake. And maybe if the patient is immobilized, that can also increase their risk of stones. It's more common in males aged 20 to 40 and tends to reoccur. The manifestations are going to be based on the location and size of the stone. The pain may be severe renal colic if the stones are in the ureter. The pain may be dull and aching if the stones are located in the kidney itself. And also that pain may radiate to the groin. The other manifestations of urolithiasis could be nausea, vomiting, diarrhea, or constipation. There may be hematuria. The patient may also have manifestations of a urinary tract infection. So we want to make sure that the care this patient receives works to the goal of eradicating the stone and preventing nephron destruction. So for our nursing intervention, we're going to force fluids at least 3,000 mLs per day by IV or by mouth. We're going to strain all urine to look for the stones, of course, and we're going to provide pain control. This is a very painful kind of condition as the patient is passing stones, usually a 10 out of 10. We also want to maintain the proper urine pH, depending on the type of stone. The medications of choice will be opioids, IV morphine for rapid pain relief, but remember, whenever we administer morphine, we have to monitor for respiratory depression. Okay, the NSAID ketorolac may be given in the acute phase. We also will administer allopurinol for uric acid stones. Allopurinol is also a medication that you can see for the musculoskeletal condition of gout. Therapeutic measures may also include lithotripsy, and this is through sound waves or shock waves where they try to break up the stone to crush the stones so the patient may be able to pass them through the urine. In extreme cases, if the stones are very large, the patient may require surgery. Client education is going to be to avoid foods that are high in oxalates if it is a calcium oxalate stone. Foods that are high in oxalates include spinach, black tea, rhubarb, and chocolate. We will also teach the patient to maintain fluid intake and adequate hydration. Okay, any questions on urolithiasis or urinary calculi? All right, so let's talk about acute renal failure and chronic kidney disease. So when we think of acute renal failure, it is an abrupt decrease in renal function. And so this happens very quickly. It could be due to the result of trauma, an allergic reaction, a drug overdose, kidney stones, or even shock. Okay, so when we think about acute renal failure, there's contributing factors. We have to look at pre-renal, renal, or post-renal factors. What is causing the urinary system to fail? So if it's pre-renal, there's going to be something before the kidneys. So maybe there's disrupted blood flow to the kidneys. The patient may have hypovolemic shock. They may be dehydrated. They may be a heart failure patient, maybe a burn injury, or they may even have anaphylaxis. But those are all pre-renal failure. So the issue is before the blood gets to the kidneys. If the reason or the contributing factor for this acute renal failure is renal, that means something is going on inside of the kidneys. Maybe there's renal tissue damage. Maybe there's trauma. Maybe there's hypokalemia, right? Low levels of potassium. There could be acute glomerulonephritis. They may have hemolytic uremic syndrome. And hemolytic uremic syndrome is an infection caused by E. coli, and it is common in children. Okay, and also acute renal failure with a renal factor could also be due to substance abuse. We've talked about pre-renal contributing factors, renal contributing factors. Now let's look at post-renal. So this is after the kidneys, okay? So urine flow from the kidney could be compromised in some way. Maybe it's due to kidney stones. It could be due to an enlarged prostate, which is prostate hyperplasia. There also may be tumors, right? Or strictures or narrowing of the urethra or the ureters. So when we look at acute renal failure, there's 4 phases. The onset, right, begins with the event or the trauma, and it can last for hours to days. I once had a patient that was actually, his boat capsized in the Chesapeake Bay, and he was treading water for about 2 or 3 hours before he was rescued. And so that was definitely a traumatic event. Not only did he have acute renal failure, he also suffered from hypothermia and some really, serious sunburn. Right now, when we think about the manifestations, those 4 phases, again, we have to think about the onset. What was the event that triggered this? We think about the oliguric phase, the diuretic phase, and the recovery phase. So the onset phase begins with the onset of the event and it lasts for days or hours to days. The oliguric phase can last from 1 to 3 weeks. This patient may have, less than 400 mLs of urine in a 24-hour period. They may have edema, elevated BUN, creatinine, and potassium. They may also have an increased specific gravity. They may have acidosis, heart failure, and dysrhythmia. So that's all in the oliguric phase. In the diuretic phase, the urine output increases, and this is followed by diuresis of up to 4,000 to 5,000 mLs of urine per day. So this indicates the recovery of damaged nephrons. In this diuretic phase, you will see that the patient has a decreased specific gravity. Hypotension and fluid and electrolyte imbalances are a concern. And that makes sense when we think about all of this urine that the patient is putting out, right? Now, in the recovery phase of acute renal failure, this can take up to 1 year until renal function returns back to the patient's baseline. Older adults are at increased risk for renal impairment. Okay, so when we think about the nursing interventions for this acute renal failure, we want to eliminate or prevent the cause. We want to correct metabolic acidosis, hyperkalemia, hyperphosphatemia, and hypocalcemia. K-exalate may be given, and it allows an ion exchange with resin and is given orally or by enema to treat hyperkalemia. IV glucose and insulin may be given, and this causes potassium to enter the cells and to leave the bloodstream, right? Calcium IV or sodium bicarbonate will be given to stabilize the cell membranes. And we also have to implement dietary modifications for this patient. When they're in the oliguric phase, they will be given low protein, high carbohydrate diet with restricted potassium intake. So for the oliguric phase, they will be given low protein, high carbohydrate diet with restricted potassium intake. In the diuretic phase or the diuresis phase, they will be given low protein, high calorie diet and restricted fluids as indicated. We also want to encourage bed rest in the oliguric phase, monitor daily weights, monitor their I's and O's, implement dialysis as ordered until the renal function returns. Okay, we also want to assess for pericarditis, which is going to be a friction rub. The heart itself is surrounded by a sac, which is the pericardium, which helps the heart to beat more easily without a lot of friction. So that's why if you hear a friction rub, it sounds like sandpaper rubbing together, right? So that is going to be your pericarditis. Okay, we want to assess for that. The medications for your patient with acute renal failure can be phosphate binders to lower phosphorus while replacing calcium, because remember, phosphorus and calcium have an inverse relationship. If your calcium is high, your phosphorus is going to be low, and vice versa. We also will administer epoetin alpha to treat anemia. Remember, your kidneys make that hormone erythropoietin. Epoetin alpha will be given because the kidneys are not able to make erythropoietin, and this epoetin alpha will help with the synthesis of red blood cells. All right, that was a lot on acute renal failure. Are there any questions? Okay, let's talk about chronic kidney disease. So acute is a sudden onset, chronic is progressive failure of kidney function, and that can result in death unless hemodialysis or transplant is performed, and it is an irreversible condition. So there are stages of chronic kidney disease, and it starts at stage 1 to stage 5. So stage 1, they have a glomerular filtration rate of 90, okay? And so that's stage 1. As we increase in stages, the glomerular filtration rate, or the GFR, becomes lower and lower. So I like to think of it as like if my cell phone is charged. So stage 1, I'm at 90% charge, right? That means my kidneys are functioning at 90%, right? That's the time. Of course, the time is to catch the patient before they end up with kidney disease. But if they're stage 1, we can implement dietary restrictions, patient teaching, monitoring their blood pressure, their diabetes, so they don't progress to stage 5, which is a GFR rate that is less than 15. So that's like if your cell phone is at 15%, it's not going to last much longer, right? So that's how I like to think about it. Now, stage 5 kidney patients are also called end-stage renal disease. These stage 5 patients, they cannot live without dialysis 3 times a week or a kidney transplant. Fun fact, George Lopez, the comedian, is actually a kidney transplant patient. He received a donor kidney. All right, contributing factors to chronic kidney disease. Diabetes mellitus is the leading cause. Uncontrolled hypertension is the second cause. Chronic glomerulonephritis, pyelonephritis, congenital kidney disease, such as polycystic kidney disease. Ethnicity, greater in African Americans and Native American and Asians. So the manifestations, they are going to progressively get worse. So there's going to be fatigue secondary to anemia, headache and hypertension, nausea, vomiting, diarrhea, irritability, edema, hypocalcemia, hyperkalemia, your pruritus, which is your itching. They may have a uremic frost on their skin, pallid gray yellow complexion. They may suffer from metabolic acidosis, elevated BUN, and creatinine. They may also have decreased glomerular filtration rate, which is your GFR. So our nursing interventions for our chronic kidney disease patient will be to maintain bed rest, implement a renal diet, which consists of low protein, low potassium, so no bananas for this patient if you see it in a question, high carbohydrates, vitamins and calcium supplements, low sodium and low phosphate. Again, that renal diet consists of low protein, low potassium, high carbohydrates, vitamins and calcium supplements, low sodium, and low phosphate. We will monitor and treat for hypertension as prescribed. Strict eyes and nose fluid replacement will be done. Please don't let your renal patients tell you that ice chips don't count. They do. If you see, an I&O kind of dosage calculation question, you will count ice for 50%. So meaning if there's 100 mLs of ice, we will count 50 mLs towards our calculation of intake for the patient. We want to also monitor the electrolytes of our chronic kidney disease patients. Do not administer antacids with magnesium or enemas with phosphorus, okay? Maintain dialysis, again, that's 3 times a week. We will administer diuretics in the early stages, provide meticulous skin care because of that uremic frost. We don't want their skin to be compromised. We will provide emotional support to the client and their family, assess for bleeding tendencies. The medications that can be given for the chronic kidney disease patient can also be your phosphate binders. That's aluminum hydroxide gel, calcium acetate, and also epoetin alpha, right? Or your erythropoietin if they have anemia, because this will help stimulate the red blood cell formation. And sometimes this patient may also need to receive transfusion of packed red blood cells. Okay, the last thing I want to mention is going to be dialysis. So there's two types of dialysis. There's going to be your hemodialysis and your peritoneal dialysis. We think about dialysis, right? Think about the job of the kidneys. The kidneys serve as a washing machine, filtering the blood, right? Washing the blood, removing the impurities. So the goals of dialysis is going to be to remove the end products of metabolism. For example, your urea, your creatinine. So we're going to be removing it from the client's blood as the patient is not able to remove it. Their kidneys are not able to remove it on its own. Also, we're going to correct any acidosis. We're going to maintain a safe level of serum electrolytes, and we will also remove excess fluid from the client's blood. So hemodialysis is we're actually cleansing the blood using what's called a dialysate, okay? And this is usually for your end-stage renal patients. Okay, and when we talk about peritoneal dialysis, this is going to be an alternative method, and they're going to use the peritoneum, which is the cavity, the abdominal cavity, to remove fluid, electrolytes, and waste products from the blood. And dialysis, in this case of peritoneal dialysis, is performed when the patient is able to have a dialysate that is instilled inside of their peritoneal cavity. Okay, so this is the dialysis. This peritoneal dialysis is the dialysis in which your patient will have to possibly change their position to make sure whatever goes in actually comes out. All right, so I'm going to stop here. We've done a lot of discussion of the renal system. I do want to afford an opportunity to look at some of the questions that you may see. On the screen, you should see question number 56. So let's talk about this question, and you may place your answers in the chat. So a nurse is providing teaching to a client who has nephrotic syndrome. The nurse should recognize that which of the following client statements indicates a need for further teaching. So when we read these questions, we have to be careful to say, okay, is this a positive or negative question? In this case, it is a negative question. This is something we don't want the patient to say. This is something that shows that they don't have a clear understanding. Okay, so I'm going to pause for a second to let you read this question and put your answer in the chat, and then we will review it together. Okay, so let's take a look at the answer choices. So this patient has nephrotic syndrome, and what indicates the patient doesn't really understand, right? So A, I can expect to have swelling in my face. Well, yes, that is true, right? Facial and periorbital swelling are manifestations of nephrotic syndrome because of reduced albumin. Okay, very good. I see the answers coming in. Awesome. Okay, so A is not correct. We do want the patient to say that. B, I will lose protein in my urine. Well, that is true. That is part of the underlying pathophysiology of nephrotic syndrome, right? And so let me cross out A. Oh, let's change that to blue. And so we'll cross out A and we'll cross out B because those are not correct choices. C, I should expect my provider to provide or prescribe a kidney biopsy. Well, a kidney biopsy is going to be needed because we have to determine what is the cause, right? So by process of elimination, D is going to be correct. And it says I should increase my sodium intake. So I'm going to tell you, and I know that you know this, we never want our kidney patients to increase their sodium intake, right? This kidney patient or this renal patient should consume a low sodium diet to reduce edema and to control hypertension. Okay, so fantastic work. Okay, we're going to go to question 58. Okay, so this is a nurse reviewing the BUN and creatinine levels of an older adult who has chronic kidney disease. The nurse should expect which of the following findings. So I'm going to give you a minute, and we have to think about what the normal values are. Okay, I'm going to give you some time to place your answers in the chat. And when we think about the BUN and creatinine levels, it's important to remember our lab values, right? And so the normal BUN is 10 to 20 milligrams per deciliter. The normal serum creatinine for males is 0.6 to 1.2 milligrams per deciliter, and that's for your males. For males, 0.6 to 1.2 milligrams per deciliter. For females, the normal serum creatinine is 0.5 to 1.1 milligrams per deciliter. So for females, the normal serum creatinine is 0.5 to 1.1 milligrams per deciliter. So let's take a look at our question 58. A nurse is reviewing the BUN and creatinine levels of an older adult client who has chronic kidney disease. The nurse should expect which of the following findings? Well, I know that right off the top that if this patient has chronic kidney disease, I would expect that their BUN and creatinine levels will not be within the normal range. Okay, so I'm seeing some answer choices between B and D. Okay, so that's really excellent that you're able to narrow it down, right, to two choices, two possible choices. So let's take a look at all the choices. So A says a BUN of 10. Now I know that that BUN is normal. So automatically I'm thinking that's not going to be a kidney patient with a BUN of 10. The creatinine is 0.3. And so that is actually a little bit on the low side, but that BUN is 10. So I don't think so, right? Now, I'm going to cross A out for that reason. So B, the BUN is 23. That's a little elevated, right? Because normal is 10 to 20 and the creatinine is 1.0. So that is actually, the creatinine is actually normal. So I don't know if I love that answer. Let's look at C. The BUN is 8 and the creatinine is 0.7. Okay. So the BUN level, I wouldn't expect it to be decreased in a chronic kidney patient. I would expect it to be elevated, really elevated. So here's an example. My mom is a stage 5 kidney patient. When she called me and she told me that her BUN was 63, I think, I was like, Mom, how are you alive right now? How are you talking to me? Right? And she is older. She is 66 years old, right? So I'm like, how are you able to talk to me, right? So C is not the best choice. So D, let's look at this. A BUN of 45. Well, we know that that's way elevated. That's outside the normal range of 10 to 20. So that, I kind of think that's going to be the answer. Now, this creatinine is 8. Whoa, that is extremely elevated because for males, the high end is 1.2. So those of you that said D, you are correct. Okay, you are correct. The rest of the choices were not correct. So what's the takeaway from this? When you see the fact that this patient is a chronic kidney disease patient, we know that their BUN is going to be very elevated. Their creatinine is going to be elevated as well. And I think my mom's creatinine was like a 6 point something. And I was like, my goodness, how are you even able to talk to me right now? Right? So the BUN of 45 milligrams per deciliter and a creatinine of 8 milligrams per deciliter is going to be the correct answer. All right, we're going to do one more question, and this is going to be question 59. And these questions are pretty tricky. Okay, so let's take a look at 59. A nurse is teaching a client who has acute kidney injury about the oliguric phase. So remember, we talked about the different phases of the acute kidney injury, right? And so what is going to be found in this oliguric phase, right? So remember, the oliguric phase lasts 1 to 3 weeks, a sudden onset, less than 400 mLs in 24 hours. There's going to be edema, elevated BUN, creatinine, and potassium, increased specific gravity, acidosis, heart failure, and or dysrhythmia. So what is going to be something that this nurse should teach her patient about the oliguric phase? Take a moment and see what you come up with. Okay, I'm just giving you some time to think about it. and think, is this a positive or negative question? And what's something the nurse should include in teaching? All right, fantastic. I see the answer choice of C, and that is going to be correct. Okay, excellent. So let's talk about this question. So the nurse is teaching a client who has acute kidney injury about the oliguric phase. So what should the nurse include? So what happens during this phase? Well, renal function is reestablished. Well, that's actually towards the end, right? The recovery phase. And we know that the recovery phase can take up to a year. So we cross that out. So the BUN and the creatinine levels decreased. So this is actually associated with the diuresis or the diuretic phase, right? The BUN and the creatinine levels decreasing. So we can cross that out, B. And then D, the GFR rate recovers. This is associated with the diuresis phase of acute kidney injury. So we know that that is not correct. So C is going to be correct. Urine output is less than 400 mLs per 24-hour period, right? And so this inadequate urinary output is associated with the oliguric phase of acute kidney injury. Okay, so we really need to be focusing on that, especially for the oliguric phase. Okay, let's do one more question if you have time, and we'll look at number 60. Okay. A nurse is planning care for a client who has acute glomerulonephritis. Which of the following interventions should the nurse include in the plan? So what is a good thing for this nurse to do for this patient with acute glomerulonephritis? So I'll give you some time to process this question and put your answers in the chat. Okay, and what may be helpful for this question is to think about what are the causes or possible causes for acute glomerulonephritis. Okay, all right. So I'm seeing some answers in the chat. Okay, so acute glomerulonephritis is an acute renal disease involving the renal glomeruli of both kidneys. It could be an antigen antibody reaction that damages the glomeruli of the kidney. And it may be a secondary response to infection in other areas of the body that usually occurs in children. So the prognosis is good if treatment is implemented early. So the contributing factors for acute glomerulonephritis could be a beta hemolytic streptococcal infection, right? Or it can follow tonsillitis or pharyngitis. With that said, what do you think now the correct answer is for 60? Should we administer antibiotics? encourage increased fluid intake, obtain weight weekly, or encourage frequent ambulation? All right, so for this one, we will think about the causes are going to be some kind of infection, right? So we will administer antibiotics because acute glomerulonephritis is related to a streptococcal infection and is treated with antibiotic therapy, and that includes penicillins and erythromycin. Okay, so we will treat with antibiotics. Okay, so increased fluid intake is not going to be the right answer because this patient is usually on fluid restriction because of fluid retention. Okay, we will also obtain the weight daily. Daily, whenever you're concerned about a patient retaining fluid or losing weight, we will weigh them daily. And this patient is actually going to be on bed rest, okay? So we will not encourage frequent ambulation. So 60, the correct answer is going to be A, administer antibiotics. All right, so at this time, this concludes our session of genitourinary disorders.